We can also have damage to other system, namely gastrointestinal hemorrhage, liver. There can be a jaundice because of traumatic damage secondary to heat for liver enzyme. We can have a patient with DIC, musculoskeletal like rhabdomyolysis, kidney injuries. This can all be seen. We can also have lung collapse and pulmonary infarction. Differential diagnosis is very important. Differential hepatic encephalopathy, hyperthyroidism, hyponatremia, delirium tremens, snake bite, tetanus. These are not so uncommon. So basically, all the diagnosis of heat stroke is clinical. But investigations we do to rule out things. Suppose we have something in our mind that this can be a case of this or that, then investigation are basically meant to rule out some other conditions. So lab investigation, as expected, there will be leukocytosis, high PCV, decreased platelet count. Then we can have microscopic hematuria, myoglobinuria in urine analysis. SGOT-PT may go up as much as 100 times. We can have disturbed coagulation study. And we can have metabolic acidosis in the ABG, lactate levels being raised. ECG may show a variety of usually tachyarrhythmias. Brady's are less commonly seen with non-specific STD changes secondary to heat-related infarct. Chest X-ray may show lung collapse, pneumonia, or ARDS. Then CT scan is basically to rule out stroke and other causes. It has, in heat stroke, it doesn't have much of a role in positively affirming a diagnosis. It is done to rule out other things. And before shifting a patient to hospital, we must immediately remove the patient from the heat environment, and cooling should be initiated as quickly as we can. Ideally, we should remove clothing, but we should not wait to remove all the clothing. The early cooling is mandatory. If we have access to immersion cooling, we should not be waiting too much. And patient should be transported by air-conditioned vehicle if possible. Now, there are some golden rules in managing these cases, which are the cooling must begin immediately and must be continued during even the patient resuscitation. And second is very, very important. Most of the people try to treat heat stroke by rehydration therapy. They think we'll give fluids, patient will become all right. This is the biggest myth, very high mortality rate. Rehydration therapy, albeit important, but alone it is insufficient for the heat stroke patient. Surface or oral temperature doesn't accurately reflect core body temperature, and the rectal is preferred method. Being fast in starting cooling saves life. Antipyretics, as I have discussed in details, have no role. And in emergency situation, the distinction between exertional and classical heat stroke is less relevant. I'll delve upon this point a bit Then we have to take breaks after some time in order to prevent heat stroke. Then we come to, besides initial resuscitation, we have to treat complications, which can be hypotension, cardiovascular, renal failure, as we do, seizures, coagulopathy. We always start by giving a person high supplemental oxygen. Fluid choice depends on the presence of hypovolemia and metabolic and other comorbidities. And important to notice, cooling alone may improve hypotension and cardiac function. So cooling definitely has the biggest role. And aggressive fluid resuscitation is generally not recommended. Must be guided by CVP and pulmonary wedge pressure monitoring. Hypoglycemia is a very, very frequent finding and simply can be addressed by glucose infusion. And dobutamine is the inotrope of choice. If at all we require to use, it is wise not to use alpha agonist, because they will call vasoconstriction, thereby stopping the heat loss quickly. We can have coagulopathies and hepatic injuries, and in which case we use fresh frozen plasma if person is bleeding, and no role of styptics like epsilon aminocaproic acid, increase rhabdomen. And one more important thing, seizures. Person presenting to us with seizures should ideally be treated by short-acting benzodiazepine. Usually what we do in our setting is injection Levira or injection valproate infusion or Eptoin. All three are not really recommended. Barbiturate prevent heat loss, so are not useful. Valproate damage liver, and phenytoin is not effective. So best in seizures of heat stroke is short-acting VZD's infusion. Lorazepam or midazolam we can use as infusion. Then respiratory complications have to be treated, and so does dyselectritemia. Cardiovascular complications also happen very frequently, and we have to be managed with aggressive cooling and fluid therapy. Tachyarrhythmias, we don't require to use cordarone or diltiazem much because they resolve spontaneously by cooling. Rhabdomyolysis, we treat it by large amount of intravenous fluid and if required alkalinization of urine, infusion of mannitol, and in worst case we have to resort to even hemodialysis.